due to the maturation of the blood clot forming between the soft tissue and the root. So if this is the situation, and if the cement enamel junction has been replaced by means of the composite restoration in the right position from an aesthetic and biological point of view, what you have to do is to measure first the distance between the soft tissue margin and the cement enamel junction and add 1 more millimeter. This is how much we will corneally advance our keratinized tissue, namely gingival recession plus 1 millimeter, because what we said before is that the keratinized tissue should not be placed exactly at the level of the cement enamel junction, because at the level of the cement enamel junction, it's very unstable position for the keratinized tissue, but the keratinized tissue must be placed above the composite restoration, above the clinical crown. And so you have to place it 1 millimeter more corner with respect to the cement enamel junction in order to be placed it above a very convex surface, smooth, stable area. The same distance, namely gingival recession plus 1 millimeter, now should be measured starting from the tip of the mesial and distal papilla, and here 2 horizontal 3 millimeters extended incision are traced. Traced means that only the bleeding line has to be created at this level by inserting the tip of the knife in the connective tissue so it starts to bleed, and then again you make the bleeding line of 2 vertical releasing incisions which are slightly divergent in apical direction. Since the papilla in the corneal position are very wide, 2.5 millimeters, 3 millimeters, you don't have to diverge too much with the vertical releasing incision, and this is very important because if the vertical releasing incisions are slightly divergent, the flap goes corner straight full, and the minimum amount of soft tissue muscles will be interested in the corneal advancement of the flap, so it's much easier for you to get the flap free completely from muscles and tensions. The area which is comprised between the 3 millimeters horizontal incision and an imaginary line which is connecting the soft tissue margin to the 2 vertical releasing incision is called surgical papilla. So in this specific type of flap, each surgical papilla has a trapezoidal shape starting from the 3 millimeters horizontal incision to the base at the level of the soft tissue margin. And obviously, this papilla has to be elevated split thickness by leaving the connective tissue and the periosteum below, which is critical for giving blood supply to the flap, and this papilla will be shifted corneal above the anatomic disepithelialized papilla, so vascular bed above a vascular bed, and so you have to displace corneal a split thickness surgical papilla. And we will see how important is to maintain the integrity of each angle of this surgical trapezoidal papilla, so to be sure to have the greater as possible blood exchanges, blood supply coming from the anatomic disepithelialized papilla toward the surgical displaced papilla. Both the papilla has to be elevated split thickness before getting to the keratinized tissue margin. Because once the 2 papilla have been elevated the split thickness, the keratinized tissue margin becomes mobile, because here there is the probing pocket depth area. And so this keratinized tissue is not firm because it's probable. And since it is probable, and since you cannot make any split thickness incision before reaching the bone crest, you have to elevate your keratinized tissue by inserting your periosteum elevator inside the probable area until you reach the bone. But the problem is, where is the bone? Is the bone immediately apical to the soft tissue margin? No. We have the probing pocket depth area, but we also have an area of anatomic bone lesions, namely root exposure with no bone and with no probing pocket depth, which means that you still have some connective tissue fibers attached, but you don't have any bone. And if you don't have any bone, you cannot make any split thickness incision. And if you don't reach the bone, you cannot cut. And so if you place a knife inside the sulcus, you cut a tissue that cannot be made split thickness because there is no bone. And so you thin the keratinized tissue that, as we said, is critical for the success of the surgery. So you have never to place your knife intrasulcularly. When you make the coronally advanced flap, the full thickness elevation of the flap must be made once the papilla has already been elevated with the knife by inserting directly your periosteum elevator inside the probable area, and with a blind elevation, you have to look for the bone. And once the bone is achieved, once the bone is get, you have already finished the keratinized tissue. Because look, how much keratinized tissue did we start with? We said 2 millimeters. Where is the bone crest with respect to the soft tissue margin? It's more apical than 2 millimeters. And so it means that when we reach with the periosteum elevator our bone crest, we are already in alveolar mucosa. And once you are in alveolar mucosa and you want to cut split thickness the alveolar mucosa, the risk is that you thin the alveolar mucosa that is already so thin that if you thin it even more, you leave only the epithelium. And if you leave only the epithelium at the level of the alveolar mucosa, there is no more blood supply to the keratinized tissue, and you are going to lose keratinized tissue during the coronal advancement of the flap. This to tell you that the full thickness flap elevation in the coronally advanced flap must not reach only the bone level, must go beyond the bone for at least 2 to 3 millimeters in order to give some periosteum to the inner aspect of the alveolar mucosa in that area where the alveolar mucosa is so thin that is attached to the root, that is attached to the bone, that if you try to thin it, it's so dangerous in terms of blood supply. Obviously, the vertical releasing incision that are still closed during the full thickness flap elevation in the mid portion of the flap has to elevated split thickness with the knife inserted along the line of incision in order to keep as much as possible periosteum along the vertical releasing incision and minimize the risk of scar formation. In the most apical aspect of your flap, once the alveolar mucosa becomes lining mucosa of the lip, and so it becomes completely filled of fatty, glandular, and muscle tissue, because it becomes that of the lip, obviously you have to make a split thickness incision in order to make your flap free to be coronally advanced with no tension. The most coronal aspect of the anatomic papilla must be desepithelialized by removing the epithelium only to create a connective tissue bed for the anchorage of the surgical papillae of the coronally advanced flap. Now we can see the step-by-step procedure with the movie. First of all, when you make, what we have to do is to measure gingival recession and also probing pocket depth. Because remember that the root that has to be treated intrasurgically with root planing is not that one corresponding to gingival recession, but also the probable area. And so if the gingival recession is 3, probing pocket depth is 4, starting from the cement enamel, the probing pocket depth is 1, starting from the cement enamel junction, we have to make root planing of 4. 3 gingival recession plus 1, that is the probing pocket depth. This is very important. This is very important because I cannot suggest you to make root planing before surgery. Because if you make root planing before surgery and you want to make root planing of the probable area, you make root planing subgingival, namely in the sulcus. And when you use a curette in the sulcus and you make root planing, you make unintentional curettage. And when you make unintentional curettage, you create inflammation. And when you create inflammation, you lose keratinized tissue. So you cannot make root planing before starting the surgery, because you don't have to make root planing only on the exposed root, but also in the area of the root that is probable. So root planing will be made intrasurgically during the surgical procedure once the flap has been elevated by replacing, starting from the cement enamel junction, both the gingival recession plus the probing pocket depth, which was measured before making anesthesia in the buccal aspect of your teeth. Then you make anesthesia. Once anesthesia is made, it's very important to consider that you don't have to make any perforation with the needle in the area corresponding to the pedicle. This is very important because once you will corneal advance your flap, it will be only the lining mucosa that is pulled corneal, and if you make perforation, this becomes larger when you pull the flap corneal. And so you have to avoid any perforation of the vestibulum depth during the anesthesia by perforating the lining mucosa of the lip at the level of the central incisors, bend the needle towards the canine and put the liquid at the level of the canine with the needle inside. The same is done at the level of the 4. You perforate it, you bend the needle in order to get with the needle inside the area of the 3. So you don't have to see any sign of perforation, of bleeding in the area of the pedicle. But making anesthesia make you aware, very simply, of the difference between the lining mucosa of the lip, which becomes swell due to the liquid, with respect to the alveolar mucosa attached to the bone and to the root. You can see very, very clearly in this case that the pink tissue is the keratinized tissue. But apically to the keratinized tissue, there is an area of about 2 millimeters of alveolar mucosa that is tightly attached to the bone and tightly attached to the root. And it is this area that I was referring before that you have to elevate full thickness. Because if you want to split thick this area of alveolar mucosa, the risk is to thin it too much and not to give any more blood supply to the keratinized tissue. So full thickness flap elevation must include also this small area that I call alveolar mucosa and that I distinguish with the lining mucosa of the lip that becomes swell when you inject the liquid of anesthesia. Now you measure gingival recession plus 1. Then you start to measure with the probe, starting from the tip of the papilla, the same distance, plus 1, 3 millimeters plus 1, starting from the tip of the papilla, and at this level, you will make your first bleeding line, which means that I use the tip of my knife to make a bleeding line just to get inside the connective tissue for about 2.5 millimeters, 3 millimeters. Then we measure the distance starting from the second papilla in apical direction and make the second bleeding line with the tip of your blade inserted inside the connective tissue. And now you trace the bleeding line of the vertical releasing incision. Where does the vertical releasing incision should be stopped when you reach the alveolar mucosa. You don't have to extend anymore your vertical releasing incision in alveolar mucosa as it was done in the past. And so you know that the extension in alveolar mucosa is enough when you see for the first time that there is a change in the quality of the bleeding. You see that your vertical releasing incision, once they are in keratinized tissue, it's a bleeding line. Why? When it is extended to the alveolar mucosa, there is a spot way of bleeding. So when the vertical releasing incision extended apical changed the way of bleeding, it's time to stop the apical extension of the vertical releasing incision. And this is done also at the distal aspect when it starts to bleed in a different way to the horizontal incision. Now that you have the bleeding line, you have the real guide for your knife to elevate, split thickness, your surgical papilla. And so you have to go in this line of incision. You have to overcome this line a bit in order to give also the tip of the papilla the right epithelium and connective tissue thickness once you will get with the knife in the second horizontal incision. And the inclination of this knife should be that one in order to leave enough periosteum in the bed, the vascular bed below, but at the same time to leave enough connective tissue in the surgical papilla, because if there is some area of the surgical papilla that contains only epithelium, they are going to go to necrosis during the healing process and will not exchange blood with the anatomic disepithelialized papilla. So it's critical to conquer the tip of the trapezoidal type of papilla in order to improve as much as possible vascular exchanges between surgical and anatomic papilla. And now I have to give the right thickness also at the mesial angle of this trapezoidal type of surgical papilla by getting with the knife intracircularly along the mesial aspect of the gingival recession and give also this area the right thickness, which is exactly the same of the thickness I gave to the distal aspect. Now that the tip can be placed, you see, the tip of the papilla can be placed above my knife, it means that the tip of the papilla has been conquered, and so I can go with my knife parallel to the soft tissue and give the same thickness to the whole apical and coronal extension of the surgical papilla until you reach an imaginary line that is the line connecting the soft tissue margin to this area of vertical releasing incision. This area, which is called the surgical papilla, has to be elevated split thickness without the need to insert the blade intracircularly. You see that once the probable area is reached, you elevate even one surgical split thickness papilla and the keratinized tissue is already mobile. Why? Because there is the probing pocket depth. And so you will be able to elevate it full thickness without the need to place a knife inside it. But the second thing we have to do is to elevate the second surgical papilla in the same way. And again, in this second papilla elevation, you have to see that there is in the entire 3 millimeters of extension, both the epithelium and the connective tissue. Once the true papilla has been elevated, it's time to take your periosteum elevator. You have to select the right one, the smooth, small, not cutting, in order to be able to elevate full thickness, the keratinized tissue, and also that small amount of alveolar mucosa which was attached to the bone, which was attached to the root, which belongs to the flap. And so full thickness flap elevation must be extended until the bone crest is reached. Then you go further apical for 2-3 millimeters in order to go beyond the bone crest and elevate full thickness also this small amount of alveolar mucosa, which was firmly and thin attached to the bone. So what we did now is to make the design of the horizontal and vertical releasing incision, to make the split thickness elevation of the surgical papilla and the full thickness elevation extended beyond the bone crest. If you want to see the profile where we are now in this specific moment, we are in this situation in which with the periosteum elevator, we elevate full thickness, the whole area of anatomic bone dehiscence, and also an area of about 2.5–3 millimeters of bone, so that this yellow line, which corresponds to the periosteum, is remaining in the inner aspect of your alveolar mucosa. But now, if you want to make your flap free from muscles, if you want to make your flap free from the periosteum, you have to make split thickness incision along the vertical releasing incision. And so you come back with the knife, and along the vertical releasing incision, you keep the knife almost parallel to the soft tissue in order to leave as much as possible periosteum along the vertical releasing incision, and you have to connect the vertical releasing incision to the mean portion of the flap, which was already elevated full thickness with periosteum elevator. And this has to be done on both sides in order to elevate split thickness vertical releasing incision in order to reach the lining mucosa of the lip. Now the flap has been elevated. You see that only that small amount, 2 or 3 millimeters of bone apical to the bone dehiscence, is elevated full thickness. The all remaining aspect of the flap are covered by periosteum and connective tissue, so that to mask as much as possible scar formation along the vertical releasing incision. But now we have to think, how can we currently advance our flap? How can we get the flap free completely from muscles? Obviously, the first thing we have to face is that this enormous amount of submucosal tissue, which correspond to the soft tissue in the inner aspect of the lining mucosa of the lip attached to the bone, is extremely thick. And this submucosal tissue, which goes from the alveolar mucosa to the periosteum, is made of glandular, fatty, and muscle tissue. And even if you make the periosteal incision, namely a very deep incision, parallel to the bone, detaching the whole submucosal tissue from the periosteum, and you want to try to pull your flap in coronal direction, this flap is terribly heavy because of the presence of the whole muscles, because of the presence of the whole submucosal tissue of the lining mucosa of the lip. So it is not enough to make periosteal incision to make your flap free from tension. But what is important is to make your alveolar mucosa of the lip free from muscles. And so you have to make a second incision, and this second incision is called a superficial incision, and it is made along the inner aspect of the alveolar mucosa, which is a completely different inclination with respect to the deep incision, which was parallel to the bone. This superficial incision is parallel to the inner aspect of the alveolar mucosa, and it's made to get the whole muscles and submucosal tissue free from the lining mucosa of the lip. So this two incision, it's a completely different story. The deep one is parallel to the bone, and is used to detach the whole submucosal tissue belonging to the lining mucosa of the lip, to the periosteum, and is made parallel to the bone, leaving the periosteum above the bone and detaching the muscle. Now you can see in this area that the area of muscle and submucosal tissue is becoming thicker and thicker, you see? Now that the lining mucosa together with the submucosal tissue, has been detached from the bone. Thanks to this deep incision, you can completely change the inclination of your knife, and with an inclination that is parallel to the lining mucosa of the lip, remove the muscles from the inner aspect of the lining mucosa in this way, so that the submucosal tissue that has been isolated from the periosteum on one side, you look how superficial you are in this cutting with respect to the deep cutting parallel to the bone, but thanks to this two cutting, one superficial parallel to the lining mucosa, parallel to the lining mucosa, the whole submucosal tissue becomes isolated. You can see here the submucosal tissue, and this is isolated, and since it's no more attached to the bone, it's no more attached to the lining mucosa, it will retract apically, and it will allow your coronary advance flap to be moved coronal in a very passive way. Passive means that there is no muscles, there is no fatty and glandular tissue in the inner aspect of your alveolar mucosa. This alveolar mucosa, it's a connective tissue, and its color should be white. When you see that there is red, yellow, fatty, or glandular or muscle tissue in the inner aspect of alveolar mucosa, it means that you were not able to isolate perfectly your alveolar mucosa of the lip to the submucosal tissue, and so there is still some risk of shrinkage. Now that the alveolar mucosa is completely free from muscles, it can be pulled, and so you can use the elastic fibers of this connective tissue to pull the lining mucosa. And this picture tells you very, very well why it's not necessary to extend the vertical releasing incision in alveolar mucosa anymore. I said you have to stop your vertical releasing incision when there is a change in the quality of the bleeding. And you see that thanks to the removal of the muscle, and thanks to the fact that the muscle retract in apical direction, you see that the alveolar mucosa goes coronal as much as you want, and you don't have to fix your alveolar mucosa to the alveolar mucosa of the adjacent teeth, but you only have to fix the alveolar mucosa to the attached gingiva of the adjacent teeth. And so you don't have to take any periosteal anchorage when you're going to suturing your alveolar mucosa, and this will minimize the risk of scar formation along the vertical releasing incision. Why? If you extend your vertical releasing incision in alveolar mucosa in order to fix the alveolar mucosa more apical to the alveolar mucosa of the adjacent teeth, you have to get to the periosteum. This creates the condition for scar formation. So you don't have to extend vertical releasing incision too much in alveolar mucosa because it's not necessary. But it's not necessary only if you understand that in order to make a flap free from tension, you have to remove muscles, not the periosteum enough, from the inner aspect of your alveolar mucosa. And now if you look at this picture, you can also understand why this is a flap with vertical releasing incision, yes, but limited to the attached gingiva, where blood supply is very important, namely at the level of the alveolar mucosa, there is no interruption. It means that this is an envelope type of flap at the level of the alveolar mucosa. That's why you don't have to make anesthesia there. That's why you don't have to interrupt with your vertical releasing incision your blood supply to the pedicle, because it's not enough. The alveolar mucosa, once is completely free from muscles, can give this horizontal oriented of the elastic fibers and becomes completely vertical without the need of extending vertical releasing incision too much. Now you protect your flap with a gauze in apical direction that is compressed with your fingers in order to have a good control of the bleeding during the treatment of the root surface. Again, you have to take your probe back. Remember that you have to measure gingival recession plus probing depth in order to know how much of the root you have to make root planing and how much of the root you don't have to make root planing. That portion of the root apical to the probe up to the bone crest, which was not probable before the surgery, it's called anatomic boundations. there is still some connective tissue fibers attached on it, and you don't have to probe not to destroy connective tissue attachment in this area. So root planing is made with the use of curette. I personally use a Mini 5 curette that is a very small cutting edge. Each half of the buccal surface is curetted by one hand of the curette, so you have to change the hand of the curette by making root planing of each half. You don't have to flat voluntarily the root surface. And the reason why you don't have to flat is because you don't have you have to improve, not to get worsen, to jeopardize the attachment between the blood clot and the dentin tubuli that has been exposed during root planing. Because after root planing, you have also to use ADTA gel, 24%, for 1 minute in order to remove completely the smear layer from the dentin tubuli. Because remember that the quality of the attachment between the soft tissue and the hard tissue depends if you are able to give stability to the blood clot, and if you are able to give adhesion of the blood clot to the root. Stability of the blood clot, I already spoken about this. You have to close the blood, not make it to escape from the soft tissue margin and from the vertical releasing incision. So you have to adapt. And you will see that we will make a very specific type of suturing, which is called sling suture, to give a tight adaptation of the keratinized tissue to a convex surface. If you don't have a convex surface, you cannot adapt any keratinized tissue, but there is a space from which the blood can escape. So you will never get blood clot stabilization. So surgery is fundamental to give stability to the blood clot. But once the blood clot is formed, you have to make this adhere to the root. And it's the interaction between the fibrin net of the blood clot to the fibril content of the dentin tubuli that makes the so-called adhesion of the blood clot. Once this adhesion is achieved, epithelium downgrowth is blocked, and so there is space and time for cells of the periodontal ligament to colonize the blood clot and to change, to be transformed in cementoblast, fibroblast, and create a condition for new connective tissue attachment formation. So, if you have blood clot adhesion, you will have connective tissue attachment formation. If you don't have blood clot adhesion, the best you can achieve is long junctional epithelium. And so you have to remove the smear layer from the dentin tubuli so that the collagen content, the fibrils collagen in the dentin tubuli, will be exposed to the adhesion of the blood clot to improve the quality of the attachment. This ADTA gel should be left in situ for 2 minutes, and then it should be rinsed a lot with saline for about 1 minute in order to remove completely smear layer. There are some situations in which you should also biologically help the cells of the coagulum to be transformed in cementoblast and fibroblast and osteoblast. And these are those situations in which the periodontal ligament cells are farther with respect to the mean portion of the root. And so they have to run a longer trip to cover the whole root. And these situations are when the root is very, very wide, when the gingival, when the root exposure is very, very deep, and especially where the root is very, very buccally dislocated. In this prominent root, the distance between one periodontal ligament on one side and the periodontal ligament on the other side is very, very hard for periodontal ligament cells to run on. And so, in this situation, there is the biological indication to add amelogenins together with ADTA, together with the root planing to the root, because amelogenins, which is called commercially Endogain, is not used to improve root coverage. It's not used to increase the soft tissue thickness. It's only used to improve the quality of the attachment by increasing the differentiations of the cells of the blood into cementoblast, into fibroblast, into osteoblast. Once these cells will meet the amelogenins, which are the proteins included inside the Endogain syringe. Endogain, when it is applied, is left in situ for 1 minute in order to leave the time for the protein to deposit. But listen, only those situations with very wide exposure, big exposure, or big prominence of the root should be treated with the aid of Endogain. If you have gingival recession with no specific buccal dislocation, or not so wide and not so big, there is no probably any clinical advantages to add Endogain, because it's enough the periodontal ligament cell to colonize the root and achieve good quality of attachment. Now, after 1 minute, you don't care about the gel, because the gel does not contain the cells, but the cells are contained in the blood clot. So the gel should not be stable. Once the protein has been worked, the gel must go away. You don't have to suction, you don't have to rinse, but you don't have to care about the future of this gel, even if this gel is not more stable at the level of the root. Now, it's time to desepithelize the papilla, and the desepithelialization of the papilla is done with a knife first, so that you prepare the base in which only the epithelium is cut away from the connective tissue, and now that the cutting surface has been prepared with a knife, you can follow this surface with microsurgical scissors that are the only instrument that allows you to desepithelize the tip of the papilla, the very triangular tip of the papilla, even if it's very narrow, even if it's very acute. But remember that with the knife, with the scissors, you cannot cut. You can follow a surface that has already been cut with the knife. Now that the papilla has been desepithelized, it's time for suturing. Obviously, you don't have to suture the papilla first, because if you suture the papilla first, you suture the papilla when there is still some tension. And so the first suture you have to make is the most apical along the mesial vertical releasing incision. This suture gets from the alveolar mucosa of the flap to the adjacent attached gingiva with a orientation from apical to coronal direction, so that when you are going to close this, you will help stabilization of your flap in coronal position with no tension. But it's absolutely critical that this first suture along the mesial apical vertical releasing incision is done after the pincet has brought the surgical papilla above the anatomic papilla. So you place the flap in the final position with the pincet, and in this position you have to suture the first mesial vertical releasing incision. Since you don't have to make any anchorage to the periosteum, because you can use the attached gingiva of the adjacent teeth, it is mandatory to use a very small needle. Small means short needle. It should should be about 7 to 8 millimeter long in order to be intramural during the suturing. Intramural means that you remain inside the connective tissue. While if you use a very long needle, even if the shape is 3/8, the risk of cutting the periosteum during the suturing is much higher, and so the risk of scar formation is bigger. So I personally use a needle 7-0 from PGA with very short needle that allows you to remain inside the connective tissue when you go from the alveolar mucosa to the attached gingiva. Now that attached gingiva has been attached, you can close this knot, leaving the papilla with the pincette, and fix the first knot. The second knot is the distal apical, which is done exactly in the same manner by placing with the pincette the surgical papilla above the anatomic papilla, and it is performed from the alveolar mucosa to the attached gingiva in apical coronal direction. And then it's closed. Now you have to make a number of single interrupted suture along the vertical release incision until the surgical papilla is passively above the anatomic desepithelialized papilla. Your keratinized tissue is placed above the composite restoration despite the presence of the lip retractor. This means that you are really very, very, very passive. When you are going to suture the surgical papillae above the anatomic papillae, but now you have to give stability to the blood. You have to give a tight abduction of the keratinized tissue to the convexity of the clinical crown, and there should be any space between the keratinized tissue and the clinical crown for the blood to get out. And so we use a specific sling suture, which is made by perforating first surgical in the mean at the base of the surgical papilla, anatomic desepithelialized papilla towards the palatal aspect. So you perforate in one shot surgical, anatomic, and palatal papilla. So you get with the needle in the palatal aspect. Then you turn with the needle below the palatal cingulum, and you go back buccally with the back of the needle below the contact point without perforating at all. So perforation is made only when you go from the buccal to the palatal, never when you go back from the palatal to the buccal. So now you are again to the buccal, and you do the same thing you did before. So one shot perforation, surgical, anatomic, and palatal papilla. So you take your needle again in the palatal aspect. You go back with the suture material below the palatal cingulum, below the contact point where you started, and you finally close the knot. Yes. Now, you take it, then I repeat it, you take the knot, and before closing, you take the needle, and before closing, you have to pull it. This is why what I can suggest is for this suture, you only have to use a suture that is soft. You cannot use a monofilament, because if you use such a thin, like the 7-0 monofilament, and you pull it, it becomes so rigid that you can cut the papilla in two. While you need a braided suture material, which should be also coated in order to minimize plaque formation, but very, very soft, so you can pull without the risk of cut. Because once you close the knot now, which is only one knot, you should see ischemia, so white appearance of the keratinized tissue that is well adapted above the convexity of the clinical crown. So in order to achieve this ischemia, you need to achieve double compression surgical above anatomic papilla by these two sutures. And so this is a compressive suture at the level of the papilla, which create good blood exchanges between surgical and anatomic papilla and perfect, really perfect adaptation, tight adaptation of the keratinized tissue to the convexity of the clinical crown. So now you understand why keratinized tissue is necessary for performing this surgery and why convexity is necessary. Because if there is no convexity and you have left a concavity or a flat surface because of the presence of the abrasion, can you achieve such a tight adaptation? No. And so blood, which comes from the pedicle, gets out. If there is blood getting out, there is also bacteria getting in. And so there will be never stability of the blood clot. You will never achieve root coverage and good quality of attachment. And before leaving the patient from the chair, you have to wait no less than half an hour and check your patient again half an hour late. And you have to check also, not only from the buccal aspect, but also from the occlusal aspect, that there is really a very tight adaptation between the keratinized tissue and the convexity of the clinical crown with no space for the blood to get out. This creates stability. This creates the condition for the blood to remain stable, for the blood to become blood clot, for the blood clot to become new connective tissue, for the new connective tissue to increase the soft tissue thickness. And if you look at also the outcome immediately after the surgery, you see that you did not lose any amount of keratinized tissue, while it's very frequently reported that with the chronally advanced flap, the keratinized tissue is lost. And you now see that after the surgery, let's say few months after the surgery, the same amount of keratinized tissue, or even more, that was present before is present and is covering the root, following the outline of the cemento enamel junction. And this keratinized tissue starts to increase with time thanks to the realignment of the mucogingival line, and the whole area which was previously occupied by gingival recession is now transformed in new thick keratinized tissue.